Hello, this week we're going to focus on skin and soft tissue infections. And so we're going to get started right away. Also, I encourage you to review the various videos that have accompanied. Okay. And as always, we're going to be doing a general coverage of all the infectious diseases. So we'll try to go through things with name of the disease, pathogen, any details that will include type of organism, structure, presence of toxin, endospore, respiration, or metabolism, locations of pathogen or any reservoirs, symptoms, signs, what is observed or detectable signs, and experience symptoms of an illness, injury, or condition. Now, signs are objective and externally observable. Symptoms are a person's reported subjective experiences. Also will include information on antitoxins, antibiotics, antifungal, antihelmintic, or antiprotozoal drugs used to treat the condition, and whether one or more vaccines exist and what is the length of time that they are in effect. So let's get started. First thing what you got to do is keep in mind that the skin has accessory structures, hair shaft, pore of sweat glands. You'll have the sensors such as the Meissner corpuscle and the Pacinian corpuscle. You'll have nerve fibers, sweat gland, and the really important areas will be, of course, the artery, the fact that we have the epidermis here, the dermis, which is the earlier part is, the papillary layer, and then underneath is the reticular layer. Now, below that will be called the subcutaneous layer that's known as the hypodermis. You are going to have beneath this maybe a fascia, and that's a thin casing of connective tissue that holds and surrounds every organ, blood vessel, bone, nerve fiber, and muscle that's in place. And this is important because some of these will be targets for some of the infections. Now, the first one we're going to be dealing with is Impetigo. This is a beta hemolytic streptococci or a Staphylococcus aureus. So it could be of either of these type of bacteria. It is a common and highly contagious skin infection that causes sores and blisters. Now, this disease will occur when the skin becomes infected with bacteria, usually either Staphylococcus aureus or Streptococcus pyogenes. Now, these bacteria can infect the skin in two ways: through a break in the skin, if the skin is otherwise healthy, such as a cut, insect bite, or other injury. Impetigo is mostly crusty, and you'll see blisters. In the crusted impetigo, this is most common type of impetigo and starts as tiny blisters. And now these small bubbles are filled with fluid, and when they burst, they leave this sort of red oozing patches that dry into yellow or honey-colored crusts or scabs. Now, bulbous impetigo, this is going to refer to large blisters that usually form. It usually starts with large bubbles filled with the clear fluid that may burst open, leaving moist red sores and then dry crusts. By the way, in certain situations, this is very common where you have a lot of little kids. Sometimes it occurs in places like daycare, etc. What happens is that impetigo blisters and crusts, now they're filled with bacteria. This makes the condition highly contagious, particularly when the site is weeping this fluid. Now, the skin is usually itchy, so the child scratches and spreads the infection from under the fingernails to other areas of the body or to another person. Non-bulbous impetigo is most commonly caused by S. aureus, which is responsible for 80% of the cases. You have to keep in mind that group A beta hemolytic strep, and that's abbreviated GABHS, accounts for 10% of all the cases, and the causative agent is a combination of S. aureus, GABHS, in about 10% of the time. The big challenge now is we're seeing methicillin-resistant S. aureus, or otherwise known as MRSA, and it's becoming more prevalent, especially in hospitalized patients today. Community-acquired MRSA is rapidly increasing. What we also see is basically a beta-lactamase-resistant antibiotics such as cephalosporins, amoxicillin with clavulanate, or dicloacillin that are the treatment of choice. Now, cephalofexin is commonly used if the culture confirms an infection solely caused by streptococci. Sometimes you have the preferred therapy, which is just oral penicillin. And part of this is because in areas of high presence or prevalence of MRSA, or if cultures are positive for MRSA, clindamycin or doxycycline are preferred treatments. Trimethoprim sulfamethoxazole is effective against MRSA as well. And so here you see a situation. Now, this is taken from one of our texts. You can see sort of these blisterings, so this would be more bulbous. And the staphylococcus will actually go from the epidermis to the dermis, and actually go into the hypodermis. Okay. Normally, these bacteria are found to live on the skin surface, and the problem is that they can go deeper, and when they do, they cause infection. Impetigo starts with painless blisters, usually on the face, especially near nose and mouth. Now, blisters fill with that clear or yellow fluid and will crust over, if you can see here. Your doctor makes a diagnosis from the look of the blisters or sores. You can see a lot of them right around the mouth of this individual. And you can see here the honey-colored exudate that has sort of dried, but it's kind of crusty. And that's impetigo. You can have this occur not just with the elderly, not with just kids, but sometimes what will happen is you have athletes, including wrestlers and football players. One person has it and some of the contamination is on, let's say, the wrestling mat, etc. Additionally, sometimes you're going to have basically another disease come in, and they may develop a secondary impetigo infection. Some of these diseases include eczema, herpes, trauma, or other types of skin disruptions. Now, the next area we're going to cover is erysipelas and cellulitis. Now, erysipelas is a skin infection involving the dermis layer of the skin, but it may extend to the superficial cutaneous lymphatics. Okay, so it can go down deeper. Cellulitis is a deep infection of the skin caused by bacteria. It usually affects the arms and legs and can develop around the eyes, mouth, and anus, or on the belly. And this is caused by group A, beta, hemolytic streptococcus. We call it strep. Now, the Streptococcus pneumoniae, that type of strep, You can have, also you have Staphylococcus aureus, and they will contribute to this. Now with cellulitis, the bacteria enter the skin and the cellulitis may spread rapidly. The affected skin appears swollen, it appears red, and it may be hot to touch and tender. Now, without treatment with an antibiotic, cellulitis can be life-threatening. Epipheralis is most often caused by group A, or rarely group C or G of the beta hemolytic streptococcus, and occurs most frequently on the legs and face. Other causes will include such other organisms such as Staphylococcus aureus, and that does include the possibility of MRSA. Okay, Klebsiella pneumoniae, Haemophilus influenzae, E. coli, and Staphylococcus werneri. Now, Streptococcus pneumoniae and Streptococcus pyrogens and Moxelia species, all of these may contribute or actually be the main infectious agent here. Epipheralis may be recurrent and may result in chronic lymphedema as well as complications of epipheralis. Commonly include thrombophlebitis, abscesses, and gangrene. It is characterized by an area of erythema that is well demarcated, raised, and often affects the lower extremities, with the face being the second most commonly affected site. Now, compared to cellulitis, another type of skin infection, epipheralis affects more surface layers of the skin. Symptoms may include, of course, redness and pain in the affected site. You may have also see fever and chills. Okay. Now, how do we treat it? Treat epipheralis with oral antibiotics that target the streptococci. This may include penicillin, amoxicillin, cephalexin, or cefadroxil. Cellulitis treatment is with dichloroxylin. Yes, I know sometimes I make mistakes. Please forgive me on that. Amoxicillin and cephalexin, and these are all reasonable choices. Now, if you have situations, you may have to go to clindamycin or a macrolide, such as clarithromycin or azithromycin, in situations where you have patients who are allergic to penicillin. And that's something that we have to keep in mind. Now, this is what you're going to be seeing here. Here's a photo that came from the text. And what you have here is a bright red salmon color to the skin. And it's a well-demarcated edge along the nasolabial fold, right around here. Epipheralis is a superficial infection, and scarring is rare. Infection can occur on the face or lower extremity. Now, if you notice here, we have purulent cellulitis, and you're wondering, is that a needle in the tissue? Yes, because what they're going to do is they're going to try to draw out some of the buildup of the pus, etc. So the focus of the infection in this elbow is the oleocranial bursa, and the organism is a methicillin-resistant Staphylococcus aureus. So they're going to try to reduce the pressure and the pain by drawing out some of that fluid. Okay. Now, if you look at all of this and you see certain points I've mentioned before, but there are 3 symptoms. So what I did was I tried to break this down. The most common cause for cellulitis in normal skin is Staphylococcus or Streptococcus bacteria. When there's a break in the skin, these bacteria that normally are living on the skin can cause a skin infection. There are 3 symptoms of cellulitis. The cellulitis appears as a red, swollen, and painful area of skin that is warm and tender to the touch. The skin may look pitted, like the peel of an orange, or blisters that appear on the affected skin. Some people may also develop fever and chills. Now, cellulitis is a common bacterial skin infection that causes redness, swelling, and pain in the infected area of the skin. If untreated, it can spread and thereby cause serious health problems. The key point here is good wound care and hygiene are important for preventing cellulitis. With cellulitis, the bacteria may enter the skin, and basically what you want to do is move rapidly, because what you're seeing is the affected skin is going to appear swollen, red, hot, and tender, and without treatment with an antibiotic, cellulitis can actually be life-threatening. So with mild cellulitis, this can be treated with oral antibiotics, including penicillin, cephalosporins, such as cephalexin, dicloxacillin, or clindamycin. If signs of systemic infection are present, and this is a key point, now it's going into your systemic circulation. Then what you need to do is go after the organisms by giving an intravenous antibiotics. At least they should be considered. And these can be either penicillin, cephalotriaxone, ceflazoline, or clindamycin. And here is a very basic image that gives you an idea. Okay, we've got Impetigo here. But when we talk about cellulitis, it's very different. You have the bullae here. Staph aureus came in through broken skin. Okay, and you really have to move on this. In some cases, you may have to move on it from the perspective of IV or oral antibiotics. Okay, now they continue to show more of this in the text, so I figured I'd include this. Basically, what you have with Epipheralis is an infection of the skin and tissue below it, and it will affect people with weak immune systems. So what do you have? You have a lot of older persons here. You've got a very young little person here, okay? And so what you have here is the group A streptococci. You can see how it's been stained out. Now, the leg is usually one of the areas that's affected. The skin becomes red, swollen, feels tender and hot, can have blisters. The other symptoms include fever, chills, headache, tiredness, loss of appetite, abdominal pain, and swollen glands. Now, you take a look over here. What we have is cellulitis. Notice the area that's red. If you notice the pinkish color, you have a less distinct edge of the infection, and that's the thing. Looks like it's spreading out. This is a type of subcutaneous infection that is usually caused by streptococci, and the different types are groups of them, A, B, C, and G. G being, and some of these others, non-purulent cellulitis. So in other words, this is one that's not going to create pus. There's usually no portal of entry. If a purulent center is present, the surrounding erythema is referred to as a purulent cellulitis. And in that situation, The cause is commonly caused by Staph aureus. Okay. Now we're going to deal with one that you kind of think, really? It's such a small thing, but for a lot of people it's not. And this is folliculitis, furuncles, and carbuncles. They all seem to be caused by Staphylococcus aureus. Now, I bring this up because really when you're talking about this and you see some of these, you go, yeah, but so-and-so had this. But it can get worse. So here we are. You have to keep in mind that a lot of the S. aureus can be MRSA, methicillin-resistant Staphylococcus aureus. Now, folliculitis is the inflammation of a hair follicle, and this is due to an infection, injury, or irritation. A furuncle, which also goes by the name of boil, is a bacterial infection involving the perifollicular tissue that usually originates from pre-existing situations. Okay, so boil appears to be painful, red, swelling around the follicular opening, and may progress to form an abscess. This is where you're going to get some of the problems with pus, etc. Now, a carbuncle is a group of infected hair follicles, not one, but a bunch now, with pus. A carbuncle is larger and deeper than a furuncle. Now, Staphylococcus aureus, as I mentioned to you before, is the most common pathogen for folliculitis and for the boils. Okay? However, gram-negative pathogens, including Klebsiella, Enterobacter, and Proteus species, may replace the gram-positive flora on facial skin, nasal mucous membranes, and neighboring areas, causing a gram-negative folliculitis and boils. This includes the hot tub folliculitis, which is caused by Pseudomonas aeruginosa contamination of an untreated water, such as what you see with saunas and whirlpools. Okay? Now, moderate to severe furuncles and carbuncles are often treated by just draining. Now, this is a healthcare provider that will do this. They cut into the lesion, drain the fluid, which of course is pus, from the inside. This is called incision and drainage. What about treatment? Well, after you've done the incision and drainage, for folliculitis, even if they don't do the incision and drainage, the first line is oral antibiotics, including dicloxacin or cephalosporins that are commonly used. For furuncles and carbuncles, if the carbuncle or furuncle is complicated by fever or cellulitis, it's going to get much more worse unless you get into a very rapid treatment here. And so the treatment with a semi-synthetic penicillin is indicated. So we have oral chloroxacillin. We may use flucochloroxacillin, cephalexin, clindamycin, or erythromycin, or intravenous naflacillin and oxacillin. Okay, I know there seems to be a lot of cillins here, but to be honest with you, you can see that you have shifts and options depending on how severe the ailment is and whether the patient has, for example, a penicillin allergy. Okay, so here is the different types of situations: folliculitis, furuncles, carbuncles. Here you see here this inflammation right around the nail. Treatment can be simply soaking in water with a liquid antibacterial soap. And the doctor diagnoses the parodontia by examining the fingernails and may have to, as you can see here, drain the pus. Okay? So individuals have to wear vinyl gloves to prevent contact with irritating substances such as water, soap, detergent, scouring pads, and chemicals for a while. Okay? You have to keep in mind something too, that sometimes these come back dependent on whether the patient has a large surface with basically the organism being resistant to certain antibiotics. So this entire diagram here is managing the paraonchia, very common there. And then, of course, you have a furuncle, as you can see right there, of nasal mucosa. Here, you have cellulitis and epidural access. So what's going to happen is, in this situation, you have the line of the incision here, and you have to have the purulent drainage here. Okay? This is a cross section here, and it shows the septa with the finger pulp. Here's a situation where you have subcutaneous abscess. A V-shaped line of incision is indicated. And the idea is that once it's pretty much emptied out of the pus, you can then probably stitch this close or let it close. Carbuncle treated with the incision and drainage approach. Okay? You can't continue to ignore the fact that you have pus. Pus, of course, is a mixture of dead bacteria cells and dead white blood cells and active white blood cells and bacteria, etc. So now what we're going to deal with is toxic shock syndromes. Now, when we're dealing with this could be from staphylococcal, and that's why they call it staph TSS, or streptococcal microbes, and that's referred to as strep TSS. Now, for those of you that don't remember history too well, in the 80s, the beginning of the 80s, you had young women that were using these super absorbent, basically tampons, and they left them in too long. And suddenly they were showing up with some type of toxic shock syndrome. And eventually the FDA just said all these really super absorbent tampons are to be discontinued on the market, because as you leave them in there, they become the setting for various types of microorganisms. Now, when we're talking about necrotizing soft tissue infections, they occur in three settings. The necrotizing fasciitis type 1, NF type 1. The mucosal barriers are breached, with mixed aerobic and anaerobic microbes leaking into the deep tissues. This results in gas-producing, necrotizing microbes. This is going to require debridement. Debridement is the removal of the damaged or dead tissue. With NF type 2, it's a microbial microbiota. It has a group A staphylococcus, which is going to produce gas, or V. vulnificus, or Aeromonas hydrophilia, or Staphylococcus aureus, which of course is MRSA. These tend to cause extensive tissue necrosis, but in many cases, no gas. Okay? Now, what about NF type 3? This is gas gangrene. It is caused by a clostridial organism, and it's going to cause myonecrosis, meaning the destruction of muscle tissue. It is always associated with gas production, with rapid progression of soft tissue necrosis, And the causative agents, right off the bat, Clostridium perfringens, which causes gas gangrene. But then you have several other related Clostridium, Clostridium histolyticum, C. novii, and C. sordelli. Now, all species cause gas gangrene after penetrating trauma. There are a couple of other little minor details here. Whenever you talk about Clostridium, they usually have the capability to go into endospores. So they may be around, and they may have been present when a penetrating trauma had occurred. Now, C. sordelli has been associated with toxic shock-like syndrome after an abortion or childbirth. Okay? And just remember, this is a very informative cross-section of the skin showing the layers and types of infections. So the upper ones are very close to the surface. In the surface, you're always going to see things like Staph aureus, etc. But as you get lower, you're going to see various other common and uncommon types of bacterial organisms, etiological organisms, and that means that they're going to account for various disorders. And then you get deeper, you get cellulitis, and you have a variety of organisms there. And then the necrotizing fasciitis, okay? That's caused by Streptococcus pyogens or the enterococcic gram-negative bacilli, okay? Now, myositis, that's an inflammation of the muscle tissue. Basically, you're going to have also a deep fascia here. As I mentioned with fascias before, it's sort of like this covering of the membrane, causing a separation between skin and muscle and a variety of other tissues where it might be present. Okay? So, here are a couple of other images to give you an idea. The staphylococcal toxic shock syndrome, the clinical features, diarrhea, cultures of Staph aureus. Of course, what's required is the tampon removal. They'll do a complete blood count, liver, and renal function studies. The person reports a headache, irritability, confusion, a fever that is greater than 102, nausea, vomiting, hypotension. Now, this is where the blood pressure is dropping really fast, okay? And desquamation of palms and soles. Sometimes this is, by the way, for those of you not familiar with desquamation, you're talking about losing some of the layers of the skin. Here's the etiology and pathogenesis. This was the vaginal colonization by the Staph aureus with the exotoxin production. So even when they did immediately remove the tampon, if there was already a colonization of some of these organisms, they would also produce toxins. As you can see here, Staphylococcus, exotoxin, TSST1, and/or enterotoxin. You're going to have the early phases present here, flu-like symptom, fever, rash, hypotension. The conditions required for the development of TSS, toxic shock syndrome, are bacterial colonization, exotoxin production, and entry portal for the toxin. Now, if you take a look over here, we have something else that's going to show up. This is called scalded skin syndrome in this individual, okay? It looks like they had an infection, and it was presumed cellulitis, but 48 hours later, what you're having is now these large bullas develop, and you find that it was MRSA. And what happens is you have a toxin, an exotoxin that is released from these organisms called exofolitin, and that causes degradation of the desmosomes, which serve as the intermolecular bridges holding the skin intact. In other words, scalded skin syndrome you need to be aware of. Some individuals, when they see little kids with this, would think that the kid was abused. And it's not that. They had basically a staphylococcal infection that went in, and literally you're losing the outer layers of the skin. Okay? All right. Also, here you have staphylococcal toxic shock syndrome, but some of the other, we'll say, clinical symptoms or signs. Here you have the desquamation of the tongue with a strawberry appearance. In other words, the strawberry appearance, the redness, and at the same time, a lot of cells being sloughed off at the tongue. You will have a sunburn type rash with TSS as it blanches under digital pressure. So you can see where the fingers are, or even the creases of the fingers. Okay? But still, there's damage to that skin. Okay, and finally we have this situation where the basically the group A streptococcal infection has gone deeper. Now the patient developed it, and this was at a site of a minor non-penetrating trauma. And so what you have is deep pain, fever, and localized tenderness quickly evolved to hemorrhagic bullae, skin sloughing, and expanding necrosis of the skin, fascia, and muscle. So they've got to go in and remove some of the damaged tissue. If they don't, then this is going to kill the patient. When we say necrotizing, basically at this point, this infection is starting to kill off some of the tissue. Okay? So, and we have here necrotizing soft tissue infections, similar to the picture the live picture you saw earlier. Okay? And sometimes what you have to do is realize, okay, in this case, this is a Clostridium perfringens. Using a gram stain, it's gram positive. Okay? And what you have are basically small chains. They're going to release certain exotoxins, okay? So the individual has fever, appears to have septic shock. They're given intravenous fluid, massive doses of antibiotic. And in some cases, because these organisms get in the tissue, they might have to resort to hyperbaric oxygen treatment. So basically, the higher pressure will, in essence, force oxygen into areas, excuse me, that will allow the oxygen to effectively kill off some of these organisms. Now, if you see in this crepitus, you have bony edema, blistering, bronzing of the skin, okay? And what they're going to do here is basically all non-viable skin, especially muscle, is debrided. So basically they're removing it, extracting it. Vessels and nerves are sometimes saved. And it's an interesting thing. If you see those little dark circles right there, that's a radiograph of a foot. And it's revealing gas spaces between tissue layers. Okay, so they're bubbles caused by the bacteria. Okay, wow. Now we're going to deal with superficial dermatophyte infections. In other words, a fungal infection. Fungal infections can be divided into superficial and deep infections. Superficial is caused by dermatophytes that invade fully keratinized tissues. such as the striatum corneum, hair, nails. Now, there are 3 genera that play a key role in these superficial infections. They are epidermophyton, microsporium, and trichophyton. Less frequently, infections are caused by non-dermatophyte fungi. For example, Malassezia furfur, and we're going to talk about this very briefly. This is going to cause Tinea versicolor. Excuse me. And that causes literally a change in the color of the skin. The other possibility is Candida species. And this is where you have cutaneous candidiasis. Now, I just want to clarify something here with you. This is not like Candida albicans. More often than not, it's going to be Candida auris. And that's the dangerous one because right now we're facing several strains that are out there that are multi-drug resistant. Okay, so we are looking at a serious issue because it may be very in the not so distant future that we will have the fungal species that can basically infect, but we will have no drugs that will be effective in countering these infections. Now, one of the things also to keep in mind is the superficial fungal infections are named by the Latin predecessor in the body region. So, Tinea barbae, this is barber's itch. It's an infection of the facial hair, usually beard and mustache area. Okay, we have Tinea capitis, the infection of scalp and hair shafts. Tinea corporis, the skin infection of the body. Tinea pedis, this is the infection of the feet, affecting soles. Interdigit clefts of toes and nails. So basically, the spaces between your toes. Okay? Tinea unguitum, and that's otherwise known as onychomycosis, and that's the toenails. Okay? So as you can see here in several of the situations here, the first one is Neocorpus, and you can see that outline of the fungal disease here. But this is all in the surface. What you have here is Tinea faciei, and it's throughout the entire face. And then we have information about managing the Tinea capitis. Okay, you can see that up on the head. A lot of times what's going to happen is somebody who's very, very young or someone who's very, very old is going to have less resistance. And by the way, if it hasn't caught up, the Tinea capitis is also well known as ringworm. It has nothing to do with worms. Okay? It is just a fungal infection in the skin, and it's caused by dermatophytes. Okay? And this gives you a breakdown of what drugs would be helpful. You want to check to see if certain animals might be carriers, etc. And they may do a skin scraping and do analysis to see what type of fungal organism is present. Now, here you see the diagnosis of Tinea pedis, in other words, on the foot. So you may have it in the toes, you may have it on the pedis and on the bottom foot. You may actually have it on the top of the foot too. Okay? And you have the dermatological conditions that mimic Tinea pedis that you need to be aware of too. As you can see, some of these situations will occur, such as moccasin damage from Tinea pedis. Now, managing Tinea cruris. Well, that's in the basically in the flaps or in the area of the upper thigh, coming close to the genital area. Okay? And what you see is the rash is going to be continuous as long as you have the redness, the scaling, etc. This may be not on just one side of the groin, but on both sides here. And the scaling, you're going to see basically, just the patches, the scaling with the sharp edges, etc., and some blistering. A lot of times this is a buildup of moisture, and it may also be a buildup of some warmth, but usually it's more the moisture. And what I mean by that is people that wear tight-fitting clothing, they might sweat a little bit more, and these things will happen until you get into something that's perhaps more open clothing, if you do any exercise, etc. Okay? All right. And finally, we have the Tinea versicolor, which is what I wanted to bring up also. Now, this is the interesting thing. When you have this fungal infection, you're going to notice situations of various colors. Even someone who is African American, where they have a darker skin, you are going to see when these infections occur that you're going to have basically sort of like these whitish dots, as you can see right here in this image. And it is almost as if it's removing the melanin, okay? And there is where individuals have to be careful. They can get a doctor to do a skin scraping. They will culture it and then determine if from those scrapings that what type of infection it is and what type of drugs that are needed. Okay, so we've gone from bacterial to fungal, and now we're going to deal with viral. We are dealing with herpes simplex virus infections. Now, this is caused by the herpes virus, HSV1, and HSV2. What is HSV? Herpes simplex virus is a double-stranded DNA. It's referred to as a human A herpes virus, and that will infect a variety of host tissues and is characterized by a lytic and a latent cycle. Now, the overall sequence homology between herpes simplex virus, HSV1, and HSV2 is interesting because when we say homology, we're talking about how much of the genetic code for HSV1 and 2 is similar? About 50%. There are homologous sequences distributed all over the genome of both viruses. Also, HSV is characterized by an extremely short reproductive cycle. We're talking hours now. Therefore, you're going to see prompt destruction of the host cell and the ability to replicate in a wide variety of host tissues. HSV infection can cause reoccurring episodes of small, painful, fluid-filled blisters that may be in the mouth, the skin, the lips. This accounts for cold sores, eyes, or genitals. Now, it was interesting because it used to be just considered HSV1 accounted for the oral herpes. And this was the spores, the sores that you would see that form crusts or scabs. The virus is highly contagious and can be spread by skin-to-skin contact, such as kissing. HSV2 is the genital herpes, and this is sexually transmitted disease, and it can be caused by, interestingly enough, either HSV1 or 2. what was a study done, several studies done in the 80s going into the 90s. They were starting to find HSV1, which is normally oral herpes, in the genitals, HSV2, the genitals in the oral area. And part of that was because of the proliferation of oral sex and things like that. So how do we treat it? Well, it can be either a topical, that is applied to the skin, medication, or oral medication, such as acyclovir, famciclovir, and valacyclovir. A lot of times, this type of infection has not always been successful in complete elimination, just blunting the onsets of further infections. So here you see herpes simplex 1, herpes simplex 2. Obviously, they're going to have the DNA in here. Obviously, the cell receptors are somewhat different, as you can see here. Okay? Then we talk about herpes simplex, and where's the virus? The virus will hide. Okay? Virus enters via cutaneous or mucous surfaces, and it will infect sensory or autonomic nerve endings with transport to the cell bodies in the ganglion. So what's going to happen is, you can see this is all going to come in to right down where the trigeminal ganglion is. Now, this is all part of the cranial nerves. And so the maxillary branch, the ophthalmic branch, you've got also, this is CN5, which is basically the trigeminal nerve, and hide there. And somehow down the road, they may come back. And there's been all sorts of speculation why they come back. Stress, certain components in food that are consumed, etc., exposure to sunlight. What happens eventually is the virus is going to replicate in the ganglia before it establishes itself in a latent phase. Okay? It will eventually come back. And here is, of course, the review of the infection, viral replication, and viral dispersal. Here's the interesting thing. You have the attachment by the virus, and then it comes in and delivers into the nuclear pore the necessary information. You have RNA polymerase. So you're going to basically send out into strands of RNA the components that make up the virus. They will eventually replicate with the help of also the endoplasmic reticulum, and eventually then you have exocytosis, and you've got a lot more viruses there. And this is just a review. I grabbed some really nice imagery because it'll give you sort of a quick review of this. How is herpes transmitted? The transmission of HSV1 and HSV2. Okay? In all cases, transmission is always the greatest during an active outbreak. Okay? You can see where some of these lead to further complications. Herpetic keratoconjunctitis, herpetic retinitis. You have also herpes simplex encephalitis or a meningitis. All right. You can have visceral herpes in the lungs, liver, and esophagus. And then you can have, of course, them in the reproductive area. And here are two images here. First one you have here is the doctor was spreading it. There's one thing that's kind of missing here. Where's the gloves? unless this was actually done by the patient herself or himself. The genital herpes, you've got a typical genital herpes reoccurrence. You have erythema in the labial folds of this young woman. Genital reoccurrences are usually going to be painful. They may present themselves as bumps, fissures, vesicles, okay? And then you have, of course, you can see the blisters right here, here. That's the herpes labius, and basically this is oral herpes infection. Okay, so we're done with this. And as always, I'm trying to give you a lot more information beyond just this brief lecture. Therefore, review the lecture PowerPoints, read all supplemental articles in module week 6, review all videos in week 6. Participate and complete the discussion for week 6. You want to keep in mind that some of the assignments may require you to review this week's videos or supplemental articles to assist you in constructing your discussion topic, and complete the quiz for week 6. And we're done.